Yeah, good evening, everyone. Welcome again to our Pan India Grand Rounds. We are lucky to have again Dr. Kish Mankad from London and Dr. Erwin Bolsoza from Zurich joining us and helping us in diagnosing these cases. We have around 11 new cases for today and 2 follow-ups with genetic diagnosis. We'll try and cover them in the next 90 minutes. We'll start off with the first case. If Dashrath wants to present the case.
Yes, sir. So this is a 1 year, 5 months old child born to non-congeneric parents who had a neonatal onset epilepsy. The seizures are in the form of epileptic spasms, which later converted to tonic seizures. On examination, child had left side human weakness, and there are no neurocutaneous markers.
Okay.
So there is a mild motor delay with the neonatal onset epilepsy having epileptic spasms followed by tonic seizures, which are resistant to multiple anti-epileptic drugs.
Was an EEG done by any chance?
Yes, sir. Outside EEG was showing right-sided hypsarrhythmia pattern.
Okay. So I have external images at the age of 1 year. On top is the T2-weighted sequences, axal sequences. And straight away you can observe in the right temporal region compared to the contralateral side, it is dysmorphic and there's a malformation of the cortical development here. It is larger in comparison to the contralateral normal side. The white matter is also demonstrating abnormal high signal changes as compared to the contralateral side. I do not appreciate any subependymal nodules, but there is this tiny cystic lesion along the right peritrigonal region. You see also the myelination pattern is slightly asymmetric in the bilateral frontal hemispheres, more on the right side than compared to the left. We go down to the coronal images. Again, you can appreciate that there is an asymmetry of the cerebral hemispheres on both sides. The frontal and the temporal regions are larger than the contralateral normal side. Nothing on the diffusion. Cannot appreciate anything on the T1 weighted sequences other than the malformed temporal and frontal regions. No subependymal cysts, no cortical tubers, but just that predominant right-sided temporal and frontal hemimegalencephaly type of pattern. So based on the imaging, you can term it as a hemimegalencephaly or a quadrantic dysplasia, and they're usually known to occur due to the mTOR pathway abnormalities. They can be associated with various syndromic associations. Tuberous sclerosis and triple pneu is are the more common causes. So I think the question was, is it a genetic etiology and does it fit into any syndrome? I would probably go in terms of these syndromic associations, though there are no neurocutaneous markers per se. I'm not sure when they're present, if it is normal or abnormal, and if it fits into a diagnosis or not. At this moment, I'll open the case for the panelists to comment upon.
I agree with your observations, Nihaal. And with these cases, you have to be very carefully looking at the contralateral side, which might appear normal instantly, but might have some lesions as well. It's very hard to comment on some selected images. Yeah. But there is a difference in the way the brain is folded in the frontal and the rest of the opercular region on the left as well. So it's important to go back to the EEG to make sure that this is just coming from one side of the head, or you've got some seizure activity from both sides. I think in the mTORopathies, the hemimegalencephaly, even I know there were no neurocutaneous markers here, for instance, MCAP and all that. Many a times we undercall the bilateral changes. That's the only thing to be worried about in this case. Otherwise, I guess if the seizures are explained by the malformation, then they're heading to some kind of a disconnection surgery. I don't think medical treatment will help. I guess Eugen will agree with me on this, with such an extensive dysplasia.
Yes, I agree. Nothing to add regarding interpretation. I just wonder, would you, Nihaal, go as far as to suggest that this is tuberous sclerosis, or just this is an option among others explaining hemimegalencephaly?
I would say option because it doesn't fit the criteria of tuberous sclerosis, at least on the imaging wise, but I would say probably evaluate tuberous sclerosis as a possibility. With infantile spasms, I think that would be one of the definitions.
Yeah, but this is nothing specific and nothing diagnostic.
Yeah.
And regarding, I'm not sure, I have no experience in this particular situation, but I could also imagine that this could be a kind of a mosaic, that if you look at the peripheral lymphocytes, this will not really, maybe not representative of what's going on in the brain.
Okay. Dr. Lokesh, Dr. Rashmi, any comments in the clinical presentation?
No, I agree. Like hemimegalencephaly, they can be have troublesome seizures. Actually, I also have a child at the moment who's whom I'm treating, but the parents have not gone for genetic testing yet. So they can have quite some troublesome seizures, I'd probably say. There are some genetic reasons, no? Some of the, I think you put it up in a small slide there.
So it's a very interesting postulation about where the mutation occurs. So if it is in the first month, so yes, as Professor Balthauser said, that there is no germline mutation, but there is a somatic mutation. So what happens that after the cells have reached the 16 cell stage, if there is a mutation, then it leads to hemimegalencephaly. If it occurs in the third month, it leads to quadrantroic dysplasia. And if it occurs in the second trimester, it can lead to a focal cortical dysplasia. So in the blood, you won't see anything. So it happens after the stages have gone beyond the start. So, and that's the mTOR pathway which gets affected at that stage, except for few like DEBDEC. DEBDEC can have germline as well as somatic mutation and tuberous sclerosis, these two.
Okay.
Okay, thank you, Dr. Ved. If there are no further comments, I'll move on to the next case. Dr. Ashmi, do you want to present the case?
So this is currently 11-month-old child whom I first met immediately post-operative following her surgery. She had had VSD closure surgery, and the next day of the surgery, they told me that she had a blood clot around the heart, which was removed the next day, and she was quite sick over the next 10 days with lots of liver problems, urine infections, and all of that. And post-operatively, she started having seizures with eye deviation, right hand and leg jerks. She was started initially on levetiracetam, did not respond, and was on valproate, levetiracetam and valproate. So after all this, she was discharged home, and an EEG was done, which was normal. So the parents, they had seen a different neurologist, and they tried to wean off the valproate, and the parents noticed some episodes. When I did the video EEG, these episodes were non-epileptic on the video EEG, but they were more like movement disorders. And she had a lot of feeding issues. So at 5 months of age, she was only like 4 kilos and all of that. So I managed all of that. And then she was first born of non-consanguineous marriage. She had low birth weight. And she's had some basic metabolic investigations, TMS, FISH, 22q11 normal. She was fine on a combination of valproate and levetiracetam until a month ago when she developed a different kind of seizure, and I thought they looked like spasms because she did it in my clinic. And on EEG, she had electrodecrement. So I gave her a course of steroids, and she responded very well to that. You have one more slide. Or is this about it?
I think, yeah, that's about it. You can go ahead.
Yeah. So the differentials with this child, she has severe global developmental delay. She's a little dysmorphic in the sense she has wide faces, but nothing to put a finger on. So the question was whether her MRI was because of HIE following the surgery that she has these changes, or whether she has a metabolic reason which we haven't detected, and post-operatively she had a stomachose because of the metabolic reason. So this was the question asked. We have sent off genetics. It's still not back yet. The results are not back yet. But the MRI, different people have said different things. I think more recently, the MRI was seen by Dr. Nimans, who's very good as far as I know. He has said it could be mitochondrial or organic acidureas or something like that. So I thought I'll just bring up the MRI for discussion. I mean, her family also was very keen that we discuss the MRI here. So I brought it up.
So the operation was at 5 months of age, that is 6 months.
Correct, correct. Yeah. She's 11 months today. Yeah.
But no recent hypoxic event.
No recent hypoxic event. Only during the surgery or post-operatively, we don't know if there was a hypoxic event. You know,
And
because
the
she
liver
had this clot and all that.
And the liver problems, do they still persist, or they have?
No, all that got better. So when she came to me at 5.5, 6 months, her liver function test was completely normal, because I did liver function test, creatinine, and all of that. All of that was completely normal.
Okay. We'll go on with the MR images. Yeah, again, sorry.
In terms of history, I mean, I'm impressed that the problems start on the day 1 or 0 after this more or less major cardiac intervention.
Yeah.
So this is remarkable.
That's right, yeah. Because before the intervention, she was quite malnourished because she had big VSD. So before the intervention, nothing major to say. They said she had attained neck control and all that. Yeah, but all the problems started post-operatively.
Okay. So moving on to the images, and on the top we have the diffusion and the ADC sequences where you can observe there are areas of cytotoxic edema involving the bilateral frontoparietal cortex, predominantly in the frontal region, and also involving the bilateral globi pallidi. We move down onto the T2 weighted sequences. You can appreciate the edematous changes, but there are areas of hypointensities on the T2 weighted sequences which correlate with the laminar necrosis. I'll pull up the T1 weighted images on the next scan, but these hypointensities are suggestive of laminar necrosis, and there are again edematous changes in the cortex. The basal ganglia predominantly involving the globi pallidi. The cerebellum is relatively spared, and there is also some degree of supratentorial atrophy and widened subarachnoid spaces with some areas of subdural collections on both sides. Here are the SWI sequences. You have tiny areas of microhemorrhagic foci in the left parietal region, bilateral thalami right basal ganglia, and also in the left temporal and right cerebellar hemisphere. The angiography, it is slightly pixelated, so I'm not able to ascertain if these are actually changes of irregular bleeding or not. But if you see, the entire picture is slightly pixelated, so I'm not very certain that there is a vasculitis type of pattern. So other than the inborn error of metabolism, I thought possibility of hemolytic uremic syndrome with a microangiopathy, but I think the kidney, and there's a normal kidney function test, and there's no renal abnormalities. Hyperammonemic encephalopathy, again, given that now that I know that the liver problems have resolved, it may be unlikely. Other possibility I thought of, given the volume loss and the cortical laminar necrosis and diffuse involvement of the brain parenchyma, possibility of a hemophagocytic lymphohistiocytosis. I'm not sure if the blood markers correlate with this possibility. At this moment, I'll open the case for the panels.
And all done. CBC and all was normal.
Okay.
Nihal, I missed.
Okay. Yes.
What is the time interval between surgery and this MR?
6 months. 6 months.
6 months.
Not 6 months. The time interval is immediately after the surgery, within 2 weeks of surgery.
Okay.
This MR was done when she came to meet me. She had the MR in her hand. They brought it to me.
This makes sense.
Okay.
Nihaal, why would you think of hemophagohistiocytosis? There is definite, border zone infarcts with globus pallidus, hyperintensity, DW restriction. That is a sort of, that.
No, I thought the time frame was 6 months.
Genetic perforin induced, where you have globus pallidus and maybe sometimes cerebellar involvement without diffusion restriction, because that's an inflammatory disorder.
No, that was just like, I thought the time frame was 6 months. I thought the post cardiac arrest was at 5 months and the scan was done at 11 months.
No. This was 15 days after the surgery. Sorry,
Okay.
Kish, what do you think? Or can I?
So just a couple of things.
I mean, all images have to be interpreted in the clinical context, and for me, this is very likely a complication following this surgery. And we are not accusing anyone, it's just interpretation. I think this is more likely the result of impaired cerebral perfusion. although this may not be documented. This would not be the first time.
So a couple of things, I agree. First of all, if this is the baseline scan at 2 weeks, the brain probably already has lost a lot of volume as well. These subdurals can't just come up overnight with the atrophy. If this is contemporaneous, as in timed close to the surgery, you did have the liver dysfunction going on at that point in time. So do you have your ammonia levels, for instance, from that time when the scan was done?
No, I'm afraid ammonia levels are not done during the liver dysfunction. So this was all managed in a different hospital. And yes. I saw her only with the scans, maybe 2 to 3 weeks after surgery. That's when I've met her for the first time.
So those two remain the big differentials here, isn't it, Nihaal? I don't think we can take it any further at this point.
Which one is because of HIE secondary to the surgery, you think?
It can be, but you're not giving a history of sudden deterioration after the surgery either, are you? Now, if you go back to the previous slide, we all thought this was done 6 months later, actually.
Yeah. No. No. On the post-operatively next day, she had this blood clot around the heart. That's what they said. That
and
was
then
removed.
Seizures following the surgery. So there was something going on at that point, isn't it?
Mm.
But did you have a clear-cut documented hypoxic ischemic event?
No, they are not very. They're not giving me that much of detail. The cardiologist. They just said that there was a clot there, and we managed to remove it. Our heart is all fine. This is all they tell me. So
the primary diagnosis here is a hypoxic ischemic event secondary to the surgery-related events around it. Again, we're not blaming anyone. And the second thing is this liver dysfunction cannot be taken away from the midst. You describe liver dysfunction, and it's important to know how bad it was. Now, going back to the metabolic question, if there is a driver for liver dysfunction, it might be good to baseline the ammonia levels and do some of those tests, but you might not find much.
No, I did them later on and they were fine. But during the surgery and during the event, I don't have the levels.
The microhemorrhage, Nihaal, can be completely explained in the context of congenital heart disease. I don't think we should go down the microangiography and secondary HLH kind of things here.
Yeah.
And the liver dysfunction could be just a manifestation of a ischemic event, because often you see it in hypoxic babies as well. So the trick will be to do a month or 2 months later the liver function again. It would have been normalized. That means it was a ischemic event. And if it is not normalized, that means there was something else going on.
Because it could also be presenting with acute hepatic encephalopathy. That can also explain the MR changes. Because for the hypoxic insult, the involvement of the globus pallidus and sparing of the putamen and thalamus is slightly unusual given the extensive involvement of the frontal and parietal cortex and subcortical white matter.
The hypoxic insult, again, I had said that before, but I have observed this in this age group. The globus is affected in hypoxic insult along with the watershed zone. This globus involvement is suggestive of a hypoxic insult. Somehow at this age group, between 6 to 12 months, because of problem with the brain, it looks like a metabolic disorder, but it is not, because there is always cortical involvement as well at the border zone area with the globus involvement. I've had patients with globus and midbrain involvement, which looks more like a metabolic disorder, but they had an acute hypoxic insult. So this is not suggestive of a metabolic disorder unless the liver dysfunction persists. If liver dysfunction improves, that means it was a post-ischemic liver dysfunction.
No, the liver function test was completely normal within the 2 to 3 weeks after surgery. When I first met her, I tested her again. Within the 2 to 3 weeks after surgery, when I first met her, I tested her again.
So that means it was an ischemic insult. And the initial
Akish, just a question. The pseudo-normalization.
Is there pseudo-normalization? At the moment, you still have
pseudo-normalization. Is there a differential?
No.
Is there a differential age when the putamen and the globus pallidus go into pseudo-normalization?
I don't think we are seeing pseudo-normalization yet. On the two ADC maps, you still have diffusion restriction in these areas.
Yeah, but what I see is T2-weighted images show involvement of putamen as well, whereas restricted diffusion is predominantly seen in the globus pallidus.
Yeah, but I don't think there is no diffusion change in the rest of the basal ganglia. At least on the left, you can see on the third picture that the lentiform nucleus is involved. I think this is a hypoxic ischemic injury as well, and you have re-baselined the the liver functions, and I would go with Vivek on this one.
Yeah, it is a diving reflex activated. It's a very likely hypoxic event, but just that any differential timings of different structures going into pseudo-normalization, I just wanted to.
Yeah, it's just the timing of the scan. It's 2 weeks, so you're kind of borderline going to start resolving all these diffusion changes. Any longer, I think you would just pick up atrophy and leukomalacia.
Sure, thank you.
Okay. Okay, thank you for that. Like initially we had told them it was hypoxia related changes only, but more recently, like they've seen other doctors and they've just brought up this metabolic thing. So thank you for that.
Okay, thank you. Next case, Dr. Rashmi, what do you want to?
So this is a 10-year-old child who had a wake-up stroke. So she woke up early in the morning and had a weakness of her left hand and leg, and she was not able to speak properly. She was not able to lift her left hand above anti-gravity, and she could not walk. And she came into the hospital. She actually went to a different hospital where she had a very severe headache when they did the MRI. So when they did the MRI, they found the stroke and they referred her to us, referred her to me. So when she came into our emergency, her NIHS score was only 2. So we just started her on high-dose aspirin. Did a few investigations for stroke. Most of it have come as normal, except with slightly low B12 and vitamin D. But most of the investigations I have done has come as normal. Currently, the child is well. She has made almost full recovery from her symptoms. She is on the high-dose aspirin, which I've started her for the next 14 days, and then I have asked her to cut it back to a shorter dose. So that is the history, but I thought the scan was very interesting.
She has a positive varicella antibody?
Yes, she has a positive varicella antibody, yeah.
Scan, apologies for this slightly pixelated images, but as you can see, there is a subacute infarct in the right caudate nucleus. Could not appreciate any areas of blooming on SWR sequences. Nothing on the visualized cervical and upper thoracic spine. There is slight narrowing at the area of the origin of the right anterior cerebral communicating artery, but these are the only MRA images I had, and they visualize proximal segments of the rest of the circular villus to demonstrate a normal appearance. So based on the imaging pattern, I would term it as cerebral arteriopathy. At this stage, a possible transient or focal cerebral arteriopathy. Given the varicella antibody, possible cause of a varicella infection related cerebral arteriopathy is my thoughts. And at this moment, I'll open the case for further discussion.
The radiologist who reported the scan, he told me that there was a stroke which had happened earlier, which had healed. So he said there were 2 strokes in the same place. Is that right? Or
no, I can see only a single area of focus of distributed diffusion. It is low on the ADC. At what time frame was the scan done from the clinical?
This was done immediately. So morning she woke up, and I think the scan was done around maybe midday, 12 or something, and by 2 she was with us.
The signal, there's a signal drop in the ADC. I could not appreciate a second abnormality.
I think we will need the full scan to ascertain that if there has been I don't think we can tell from one picture.
Okay, fair enough. Yeah. Yeah.
So what were you thinking? Were you thinking of chronic arteriopathy, something like?
No, arteriopathy only was what he said.
Okay.
But he said if she didn't have a stroke, I would have called it migraine. That's what he said. I don't know.
But there's an infarct here. I don't know why would you call it as migraine.
You can't. You can't call it as migraine. Yeah.
But we haven't confirmed the arteriopathy, have we now? It might be a vasculitic thing related to varicella, but you haven't. Have you confirmed an arteriopathy here?
You mean to say to do CSF analysis and all that?
You've done that. I'm talking about the vessel imaging that you have, Nihaal.
No, these are the only vessels. These are only images I have.
The MCA is quite pristine based on what I can see from here. And
Yeah.
that narrowing of the ACOM will not explain this, right? But yeah, it could be a situation where we don't see much in the way of vessel change, but we still have a focal cerebral change, whether you call it arteriopathy or a vasculitis in itself.
I did test her ESR and it was normal to look for any other causes of vasculitis. I did not go beyond that. I did not go more of the other tests beyond that.
Dr. Munga, wouldn't you term it as a FCA of the inflammatory type if it's a vasculitis?
FCA of the inflammatory type.
Yeah.
Yeah, I mean,
Yes, sir.
probably what it is, but we haven't shown any stenosis or occlusion or narrowing of the. It is possible. I'm just mindful. I know you've said there is no calcification, but what's the history? Has he resolved clinically completely?
Yes, she has nearly fully resolved.
What?
The left hemiplegia has almost completely gone. So you make her do some really tricky thing, you might find a little bit of a deficit, but it's all completely gone.
Okay, so it's not totally resolved. It's not a mineralizing angiopathy situation, right? Is what I'm asking. I know the MR doesn't always show calcification.
Yeah.
But
At 10 years, it could be slightly unusual. They usually present with the age of a toddler's age group but anyway, yeah. Without the CT, I cannot rule out mineralization, but
I thought mineralizing is in younger kids, no? When they have a small trauma and then they.
Yeah, trivial trauma, usually.
I don't know about the age range. I think Lokesh
It was 10, yeah.
Yeah. Usually in infants up to 2 to 3 years, they say.
Yeah.
So obviously to confirm the diagnosis, we'll need a repeat scan in about 6 months, correct?
Yes.
See the progression and all that. So during that time, what sort of imaging will be useful?
Well, not to confirm the diagnosis, but it is recommended that if we are calling this varicella vasculitis and related to that, then I think the idea would be to go, unless they have other events, but otherwise to go on an annual surveillance. In fact, there was a great talk today at the BPNA stroke meeting by Vijaya, especially on this topic, and the recommendation is to scan them annually for at least 5 years.
Okay.
And it would be an MRA. I don't think we will do a CT scan necessarily.
Now you were saying something about vessel wall imaging, no? Would you like that? Should we do that in 6 months or 1 year?
No, what I'm saying is based on the standard of care, which is the MR angiogram, which was done, we haven't an obvious narrowing that, within the middle cerebral artery. But you can have that situation with varicella anyways. And that is why I thought, could we be dealing with something else as well? Apart from the fact that there is varicella, there's nothing else that has happened here.
Yeah. No, another thing was that I have written varicella antibodies, which I screened for as per the stroke guidelines. And then I realized that all of us have varicella antibodies because we would have all had chickenpox or had the vaccine, correct? So it doesn't really mean anything.
We didn't have clinical chickenpox, no.
No. You'd had clinical chickenpox and then you develop varicella antibodies. So then I was thinking, yeah, it doesn't mean a lot.
Well, it's up to Nihaal if he wants to recommend a CT scan now.
No, I wouldn't recommend a CT scan, given the age.
Right.
And it's Dr. Lokesh might want to comment on that. Because
the oldest age reported by another colleague of ours in Jikna is 6 years. So we haven't seen anybody beyond 6 years of age with this.
So in terms of radiation, we can also forget the CT, can we?
Yes, I agree. I don't think it's.
But it's in perfect health. It cannot be better. Are you considering to continue with normal dose aspirin?
Yeah, for 14 days, I've given her high dose, 5 mg per kilo. And after 14 days, I'm going to reduce it to normal dose aspirin, 1 to 2 mg per kilo. And probably continue it for 2 years minimum. And then I'll see and then take a call on that.
Thank you.
Yeah. So shall I repeat her MR in about 6 months or a year?
Yeah, why not?
Yeah, okay. I'll repeat it in 6 months and see whether there's any progression of this arteriopathy or anything like that.
Yeah, the only thing is we haven't demonstrated arteriopathy, so we will not be able to say if there's progression or not.
Huh.
We just have to see if there's a normal appearance of the intracranial arteries and if there are no new strokes, no new infarct. That's all we can comment on.
No new infarcts and the normal appearance of the arteries. Okay, fine.
Yeah,
I'll do that in 6 months. Okay. Thank you very much.
Okay.
Rashmi, she had episodes of headache in the past, no? So, like
Yes,
even
she has
prior
had.
to this neurological deficit, she had a headache in the occipital region. Can it be an intracranial dissection? Would CT angio add on additional information in this patient?
I don't think so. I don't think it is intracranial dissection. She's had
Dr.
episodes. She had one episode of headache in the past. And like I said before, the radiologist had said that there was one small stroke before in the past. So I wondered whether that during that episode of headache, she'd had another small stroke. And this was the second one.
Dr. Nihaal, would you recommend CT angio in this child?
Given the normal appearance of the MR, I wouldn't think so.
Definite history of headache preceding the focal deficit.
No, headache is after the focal deficit.
And she had recurrent headaches in the past, and vascularity screening is negative.
She had one episode of headache in the past, severe headache similar to this.
Okay.
And I presume that it was because the radiologist had said there was another smaller stroke, which you're not able to see on here. I presume that maybe she had had one episode there.
Can I just say headache is very prevalent.
Mm-hmm.
You cannot associate type headache. I mean, you can have anything within a headache period. And there are papers who had a focus on occipital headache. Occipital headache has not a particular special situation compared to any other normal headache. It does not deserve special investigations.
Thank you for that. I agree.
I think in the interest of time, if I dare to say, we should continue.
Yes. Thank you very much.
All right. Thank you. Thank you. Next case is from Romit. Romit, if you're here.
Yes, sir. So it's a case of a 9.5-year-old girl which presented with recurrent neurological deficits. The first episode happened in Feb 2018. She had a febrile illness on and off for about 2 weeks, and which was followed by gradual painless loss of vision, reduced speech. She was encephalopathic, deranged sensorium, had transient loss of bladder and bowel control, was diagnosed with possible demyelination at another center, and she was given pulse steroids and IVIG. And within 1 month, she improved well. Only the visual acuity did not improve to the baseline. So she had some deficit. So she continued to have this type of episodes, multiple episodes, even after 6 months of oral steroid. And she was never given any other immunomodulation, only steroids and IVIG every time. This time she presented to me with, again, painless loss of vision. She could count fingers only at 1 feet, and relative efferent pupillary defect was present. We can move to the MRI.
Okay. Yeah. Okay. So the MR is after the 7th episode.
A question to the history, if I may. I have missed it. Was the loss of vision bilateral or unilateral?
Bilateral loss of vision.
Okay. The MR is a recent one?
Yes, sir. So actually, I sent you multiple MRIs. The pics are of the older MRIs, and the full CD that I sent you, that was the recent MRIs.
So essentially, you're giving optic neuritis here, isn't it, in the story?
Right, sir.
Yes. I only put up the CD. I wasn't aware of the fix. So this is the latest MR. From it.
Yes, sir.
Okay. Sorry, I didn't put up the earlier images. So at least on the latest MR, we have confluent white matter abnormalities involving the bilateral cerebral hemispheres, no restricted diffusion, periventricular areas going up to the subcortical regions, also involving the central white matter and the pulvinar thalamic nuclei. Posterior fossa, the cerebral peduncles are also involved. Cerebellum is slightly spared. There is some degree of volume loss in the cerebellum. and also in the supratemporal brain parenchyma. So predominantly a white matter abnormality also affecting possibly the bilateral thalami and the cerebral peduncles on both sides. Just a question to Romit. Sorry, I'll just finish up with the scan. T1 weighted sequences, no abnormalities per se, nothing on the SWI images. Contrast, cannot appreciate any enhancement given that there are subcortical areas of slight difference changes on T1. They correspond with a similar intensity on the post-contrast images. So I wouldn't attribute that to abnormal contrast enhancement. Fat site images of the optic nerves, they are slightly reduced in caliber. The right optic nerve is slightly hyperintense. Also, the distal segment of the left optic nerve is hyperintense. The optic chiasm also demonstrates these hyperintensities. Just a question to Romit, since we don't have the earlier images, were the MR changes the same or have they progressed?
Yeah. Right. So initially, the MR signals, the initial MRI showed only thalamic signal changes along with longitudinally extensive transverse myelitis with optic neuritis. So, but the white matter changes have been progressing after each MRI. And after steroids, there was almost complete resolution within 6 months. But every time she has these episodes, there is more and more of white matter involvement. Initially, the involvement was limited to thalami, optic nerves, and transverse myelitis.
Okay.
And you haven't got the MOG back yet from anywhere.
So we have, yeah. So initially, she has been worked up multiple times. NMO, MOG, oligoclonal bands. Every time the oligoclonal bands and CSF protein have been in the normal range. So the demyelination workup is essentially negative.
But in the very broad sense, this is relapsing demyelinating syndrome. Despite
yes,
of antibodies. And I'm not an expert in that field, but I just wonder whether in view of these multiple relapses, and you have likely also some degree of optic atrophy, whether you should escalate your treatment by rituximab or whatever.
Right, so we have planned for rituximab for this child. Initially treated as an acute, because she presented in an acute state, we've given steroids and IVIG, and the plan is to give rituximab, but we don't have a serological diagnosis, and I was thinking whether it is a clearly demyelination or should we think of some other entities as well, based on the clinical picture and the MRI picture.
I can't think of any other diagnosis here. I think if you can spend more money and repeat a MOG in another lab, it might be positive, but I can't think of anything else.
No.
Nihaal?
No, just the question was, is it a genetic abnormality or not based on the confirmed nature of the changes, but the clinical presentation is of a relapse and remitting course. So I'm not aware of any genetic abnormalities which present with such a clinical presentation.
So Romit, was it a live cell-based assay or fixed cell-based assay for anti-MOG? Where did you get it done?
This time I got it done at Amrita. The last couple of times it was done at Lalpath.
Okay, because it has to be a live cell-based assay. And Nihaal, would you think of CNS hemophagohistiocytosis here?
No hemorrhage, cerebellum is spared. I would say less likely.
Can you go back to the one slide? Just the next one. Okay, no, next. I just want, excuse me. Okay, next.
Yeah, that's
next.
Okay, yeah.
There was
That's the last slide.
Visual evoked potentials were delayed.
Yeah.
I mean, this is just non-specific. It just means anything is wrong with that optic tracts. It's not a proof of optic neuritis. It just means, I mean, you have also relative afferent pupillary defect. I mean, this optic nerve is not healthy. And I wonder whether perhaps you could have more information by OCT, optical coherence tomography. How is that the optic nerve? also as an argument to augment your treatment? Just a thought.
I haven't got it done. And does it anyway change our diagnosis or help in our diagnosis? I am not sure. If we get an OCT, means not the treatment part, but the diagnostic part.
So OCT is very helpful if you have benign intracranial hypertension associated papilledema, because you don't want to do repeated CSF. So if you do OCT, that's a very good follow-up marker. But Yugen, could you elaborate how is it useful for optic neuritis as OCT usefulness for diagnosis and treatment? Definitely for BIH it is, but for optic neuritis.
Okay. So OCT mock in another lab.
Okay. So repeat MOG, Romit, for now.
It's negative, sir. Repeat MOG and MO is negative. Repeat oligoclonal bands is also negative.
So seronegative demyelination, but increase the
Yeah,
dose.
Yeah, I'll plan on another immunomodulation for recurrence for the relapse.
Okay, great. Thank you. Next case, Romit.
Yeah, so this is a 15 years old boy, had absolutely normal development and then presented with subacute onset rest and postural tremors for the last 2 months. No other neuropsychiatric disturbance or sleep-wake cycle disturbances, no other focal deficits as such. So looking at the MRI, the differentials, I just wanted to know, is there any differential, because the patient is lost to follow-up. They didn't want to accept the diagnosis. So yeah.
So we have the MR images, T2 axilla and flares, and we have hyperintense changes in the bilateral basal ganglia and the thalamus, and also involving the midbrain and the pons. Coming more superficially, the frontal subcortical white matter also demonstrates the symmetrical areas of flare hyperintensities, with relative sparing of the cerebral peduncles and the red nuclei. On the diffusion weighted scans, there is some areas of restricted diffusion in the bilateral thalami and also in the abnormal areas of the midbrain. SWI sequences, the basal ganglia slightly demonstrate slightly low signal intensities. Also, the hypothalamus and the substantia nigra demonstrate these low signal intensities, but given for a 15-year-old child, we'll say they are probably slightly abnormal. T1 weighted sequences, nothing to comment upon on the T1 weighted sequences. Overall, there's a reduction in the supra and infratemporal brain volume. So once this case was sent, I thought of this companion case which I discussed earlier, which had similar imaging findings, but this patient had a positive finding of KF ring. And again, if you see, the imaging findings are very similar to what we have seen in our case, the index case. And that turned out to be the diagnosis of Wilson's disease. Other differentials, this is a recent review paper, but none of them actually fit into the clinical and the imaging criteria. The only thing is, we had a similar case previously, which was actually from Romit, and that came out to be positive for NMDAR antibody encephalitis, if I'm not mistaken. Romit?
Yes, sir.
Nihaal, just a detail.
Yeah.
We have discussed this case earlier, and I think that the age of the child is not correct. It's not 5, it was 15, because at 5 years you may have hepatic Wilson disease, but not neurological. So this companion 5-year is not correct.
Okay. So this is 15 now. So the question was, in literature it is mentioned that 5% of cases don't present with the KF rings, but how common is common and how uncommon is uncommon, and what other diagnosis possibilities need to be considered?
I think, if I may say, Wilson disease is very high on the list, and this is one of the few treatable conditions. So it's a pity that you have lost this child, if I understood correctly, because he needs urgent treatment. This is not reversible on the long run without treatment.
Did the child have a slit lamp examination to look for the KF ring, or it's a naked eye examination?
No, it's a naked eye examination, and slit examination was told, but they didn't turn up actually.
How
they were
much
not
was the 24 hours urine copper and serum
they
ceruloplasmin?
they didn't get any investigations done because they were not acceptable of the diagnosis based on the MRI. I wrote the following investigations, but they just didn't do it.
Okay.
Too bad. I experienced a situation where parents refused treatment for 2 years, and it was just devastating permanent dystonia as a remaining symptom.
Okay. If there are no further comments, I'll move on to the next case. Robert, maybe try and contact them.
Yeah,
Slightly
sure.
harder, I guess. Yeah. Okay. Yeah. Next case again from Robert.
Yeah. So it's a 2-year, 10-month-old boy. He had normal perinatal history, no sentinel events. He presented with developmental delay, cognitive more than motor, and he was not gaining any new milestones. So he achieved neck control at 15 months, rollover by 24 months, but he has not gained any new motor milestones. He had very poor recognition, was not recognizing parents, had no social smile, so cognitively severely delayed. He had epileptic spasms at 6 months of age, which were not diagnosed properly and improperly treated. But anyhow, they stopped. And now he presented with multifocal seizures. He had microcephaly, Mongolian spots, but not aberrant or palpable. And he had central hypotonia. He had very poor tracking, and although perception of light was present, and fundus examination was normal. So wanted to know the differentials based on the MRI. Are we looking at a mitochondrial? Yeah.
Okay. But blood lactate was normal.
Blood lactate was normal.
Okay. So coming to the images on top, as you can appreciate, this is a microcephalic head. The head is overall small in size. The white matter is also reduced in volume. If you observe on the infratemporal region, there is atrophy of the vermis and the cerebellar hemispheres on both sides. Some periventricular hyperintensities are demonstrated. Also, some subcortical hyperintensities in the perisylvian and frontal regions. On the FLAIR images, the vermis demonstrates slightly hyperintense cortex. Nothing on the diffusion and nothing on the SWI sequence. Coming to the coronals, again, you can appreciate this cerebellar volume loss in comparison to the supratentorial brain parenchyma. The sagittal images, again, the vermis demonstrates a diffuse changes of cerebellar vermin atrophy, and on a background of a microcephalic head. So at this point, thinking of possible diagnosis with an approach to these infratemporal findings, these are a list of disorders which can present with cerebellar atrophy and cortical hyperintensities. And I would open the case for further comments.
Can I add to you? We have discussed this before. This is a male with microcephaly and seizures and Engelmann-like presentation with cerebellar atrophy and cortex hyperintensity. This would fit very well to Christianson syndrome. This would be my first bet. This is an X-linked disorder. You can look in OMIM 300243. I can't pronounce the gene. So this is an X-linked gene.
The gene is
it's
SLC9A6.
9A6.
Yeah. All right.
Okay. Yeah. Thanks. So I think it will help with the genetic testing.
Okay. Thank you, Aidan. Next case. One of the fellows, Dashrath or Geeta, want to present this? Actually, I think you may not have seen it, but okay, I'll go ahead with the presentation. So this was a 6-month-old child presented with global developmental delay, had epilepsy, infantile spasms, clonic seizures with cerebral vision impairment, and also had a small head. There was no history of birth asphyxia. This was a term child. There's a maternal history of 3 abortions in the first trimester. Just wanted to show the MR images, which are mostly pathognomic of the condition. You have supratentorial volume loss, dilated, scalloped, irregular, wavy, outlined lateral ventricles, atrophy and gliosis of the bilateral basal ganglia, and also reduction in the volume of the bilateral thalami. The inferior aspect of the midbrain demonstrates this characteristic figure of 8 appearance. There is reduction in the volume of the brainstem. And on the coronal images, you can appreciate that there is volume loss in the supratentorial brain parenchyma, wavy outlines of the lateral ventricles on both sides. The cerebellar hemispheres are more severely affected in comparison to the vermis. Sagittal images, you can appreciate that the corpus callosum is extremely thinned out. There is hypoplasia of the brainstem. No abnormalities on the SW-weighted sequences. So based on the imaging findings alone, we would consider a possibility of PCH type 9 due to AMPD2 mutation. They present with PCH and have a dragonfly appearance. The dragonfly pattern is more commonly seen in PCH2, but can also be seen in the 1, 4, 5, 6, and 9 subtypes. Figure of 8 appearance as seen in the lower midbrain is characteristic of this disorder. And at this time, I'll open the case for further comments or discussion. We don't have a genetic confirmatory diagnosis.
I don't think there's a differential.
I agree. Very classical constellation.
Okay, thank you.
Autosomal recessive condition.
Yeah. Next case is from Dr. Vivek. Dr. Vivek, do you want to present the case?
Yeah. So this is a 11-month-old male child who has been having seizures, tonic seizures from 2-month age, and they progressed to infantile spasms. Again, he had no progress, hypotonic, no visual contact, central hypotonia, and there's no family history of similar illness. Next slide. Again. These are the seizures. Just subtle spasms. He has a cluster of spasms at his shoulders, and he doesn't have any visual connect. He has these motor stereotypies of his head, keeps the horizontal no sign of the head, and arms flexed and frog posture, but no obvious dysmorphism and poor weight gain, failure to thrive. Next.
Is the hair normal, Dr. Vivek? Just as a
there was a I didn't actually, so except for seborrhea, now I haven't noted that. So like something like this kinky hair, or but when I look at it now, when you show me, maybe they look abnormal, but I have to look at it when he comes. So I haven't looked at it specifically.
Okay. Right.
Yeah. And he had a blood lactate which was high normal, and he had a normal metabolic profile, and hips arrhythmic EEG for suggestive infantile spasms. We have sent his genetic workup, which is awaited. His MRI has some interesting changes on diffusion images. So Nihaal, could you?
Yeah. So we have the diffusion weighted sequences on top, and you can appreciate that there are areas of restricted diffusion involving the splenium of the corpus callosum, and also the brainstem tracts. Central tegmental tracts, the brainstem tract also demonstrate this area of restricted diffusion. The deep gray nuclei, that is the basal ganglia and thalami, are relatively spared. At least there are no abnormal signals on the diffusion weighted sequences. The T2 weighted sequence, you can appreciate that there is a generalized reduction in the supratentorial more than infratentorial brain volume. No abnormal signals in the deep gray nuclei, but an overall appearance of a generalized atrophy of the cerebral hemispheres on both sides and some degree of vermin atrophy. There's a tiny focus of caudothalamic hemorrhage. I think this is an old hemorrhagic foci, but no other areas of blooming on SWI sequences. Spectroscopy, the focus is on the thalamus. The voxel is on the thalamus. It has a small lactate peak Not sure of its significance. Possibilities on the diffusion-weighted sequences of the brainstem, mitochondrial disorders, SERPON mutation. I cannot think of any other possibilities other than a neurodegenerative disorder. And if the clinical phenotype is more likely and helpful, helpful than the imaging phenotype. At this point, I'll open the case for discussion.
Would you keep neurometabolic entities within that differential at the moment, Nihaal, apart from mitochondria?
Yeah. Which other ones are you thinking of?
I'm thinking of rare ones, biotinidase and all, but you don't have any other clinical samples here, right?
No. Yeah.
Can
I was thinking of yeah, I did.
This MR reminds me of a case report with GPI anchor disorder with PIGA deficiency. This is a whole group of conditions, about 30 different genes in that pathway, and they can make this kind of, I mean, this picture is not specific. Delay, seizures, and so on, poor visual contact. This is nothing specific. So this is genetic, but not only consider mitochondrial.
Yeah, I agree.
Yeah, they can also have significant peripheral neuropathy in PIGA with epileptic spasms.
What was the medication? Was rigobatrin given, just in case to rule that out?
So he was given steroids initially, and the MRI was done. So he was given vigabatrin, but MRI was done before the vigabatrin.
Okay.
And he's got hyperreflexia. So he doesn't have. So he's got central hypotonia, hyperreflexia with hypotonia. Is this a group which also has alkaline phosphatase high, some problem, PIGA group, alkaline phosphatase related, which can sometimes is a screening marker?
Yes, some of them have.
Yes.
Yeah. Okay. I'll come back with the update of the genetic results and see what it shows.
Yeah. All right. Thank you.
Oh, thank you.
Next is Dr. Kavita.
Yes, sir.
Dominic?
Am I audible?
Yeah.
Yes, sir. So, good evening, everyone. So this is a case of 7.5-year-old male child. Actually, he came to us on the like after 3 months of the illness. So the problem was he had a sudden onset of left hemiparesis that was noticed by the mother on awakening, and there was a deviation of mouth towards the right side. So this was the complaint. They came to us and admitted, and we have done a CT for that. And on asking further, they have given a history of fever since last 3 days. This was the history. So we have done a workup for the stroke and for the fever. So the stroke workup, everything, COVID antibody, MISC workup, and 2D echo, sickling test, ESR, ferritin, everything has come normal. There is nothing. What we have not done is protein C, protein S, and lupus anticoagulant factor V Leiden mutation. That we have not done. But others like sickling, ESR, and D dimers, fibrinogen, LDH, entire coag profile was normal, sickling and all. So we repeated an MRI after the CT. That will come now. Sir, please show the CT and MRI.
Yeah, sure. Yeah. So CT was on October 21. Plain non-contrast CT, no vessel imaging was done, but on the CT, I just appreciate this tiny focus of hypodensity, non-specific. Cannot appreciate any obvious infarcts or lesions in the CT scan. The MR was done a week later, and on the MR, you can appreciate these multifocal tiny areas of infarcts in the centrum semiolus and the right anterior frontal periventricular region. Nothing on the SWI, no hemorrhagic foci within the infarcts. Coming to the angiography, the right intercalateral artery is reduced in caliber as compared to the left. As you go more distally, the distal segments are not visualized. Up to the MCA, up to the origins of the MCA, again the MCA is demonstrated on both sides. There is non-visualization of the right anterior communicating artery. On the MIP images, you can appreciate the difference in the calibers of the intercalated artery on both sides. The neck angio did not demonstrate any abnormality. Then we had a follow-up scan. Ramani, was there any further events, clinical abnormalities?
So, sir, yes, sir. So actually this MRI has been done next day after the CT, and the child got improved over 3 days and he doesn't have any deficits right now. The power was also more than 4/5 at the time of discharge during the first illness only, and he was discharged on aspirin. They have not done diffuse vessel wall imaging or anything to think of any vasculitis. They have not done any CSF. Only the child was discharged on aspirin and child is doing well. So they have repeated. So we repeated the MRI after 6 months of illness. So first presentation was in October and we repeated in April this month. And in between the child is doing well only on aspirin. So our doubt is whether to treat this child like a vasculitis, because there was a fever onset was there prior to that. And also the mother was giving the complaint that in the past history, like 4 months ago, 4 months prior to the first illness, the child had a transient weakness of right lower leg. So once there was a right-sided monoplegia, and now this is a left-sided hemiplegia. So are there any collaterals, or should we think of any moya like, or is it like arteriopathy? So how should we treat this? That's the plans.
Okay.
Second
so
MRI.
Second MR. On the second MR, you can appreciate the chronic ischemic changes which are seen on the first MR in October. No new abnormalities are demonstrated. Again, nothing on the stabilized sequences. Coming to the angio, again, similar changes were seen in the intercalated artery. It's again reduced in caliber. I could not appreciate any collaterals formation, especially in the vessel systems or the lenticule striate regions. So I have not put up the images, but there were no collaterals in these areas. And also in the MIP images, you can see that there are no collateralization, no collateral formation, but a slight improvement of the intercalated artery, but still it is reduced in caliber. Again, going down to the possible diagnosis, is it a chronic progressive cerebral arteriopathy? Though clinically it has not progressed, and imaging wise also I do not see any progression. And at this moment, I'll open this case for the comments.
So, good evening, Dr. Kavita here.
Hi.
These the area of these impacts looks like watershed, right? Like you get in Moya.
Yeah.
Yes, and what we were told was that in the previous scan there was a stenosis of multiple segments of ICA as well as right MCA and left ACA.
Okay.
So
the
what
right
is your
ACA
comment on that?
The right ACA is not seen, but left ACA, I think it is patent. I cannot appreciate any stenosis of the anterior cerebral artery, the left anterior cerebral artery.
Okay, and what is the interval change in the MCA and ICA as compared to the previous scan? So is the stenosis improving or is it the same?
So this is
Are there any new arteries involved?
This is the scan in October. As you can see, the right ACA. The right ACA is even better demonstrated on the follow-up scan. There's no stenosis of the MCA on both sides. The left ICA is normal. No stenosis of the terminal portion of the left ACA. So imaging wise, I cannot term it as moya, but it can be a possibility.
So if there is no progression, then we just label it as a multifocal arteriopathy.
Chronic progressive cerebral arteriopathy.
So for progressive, then new vessels should be involved. There is no new vessel.
Sorry.
Yeah. Okay. And there is no suggestion of moya as well, because the second
Nothing
episode that he got, because
Yeah.
the TIA which happened was on the opposite side. So
Okay.
that's why we are not able to correlate like which is the, because MCA on the left side looks normal.
Yeah.
That is, we don't have any explanation for the right monoplasia that he had in between. So any other imaging modality which can make it more clearer, or this is enough here that we don't need any further imaging, and maybe just after 6 months again we document that there is no progression of any arteriopathy. What is the opinion regarding the etiology here?
Nihaal, at what level does the internal carotid occlude? I'm trying to figure that out on the right side.
It's from C5 to C7.
So in the report they mentioned from right from C1 itself, the cervical.
No, the
part.
complete occlusion, not the narrowing, complete occlusion of the.
Okay. But there is a narrowing
So
right
it's,
from C1, right?
yeah, there is a narrowing right from C1.
Yeah.
Kavita, any history of trauma, any acquired problem that might be going on here, like a dissection?
No, though there
No,
was
sir.
a history of fever, but I mean, as I said, as she has already mentioned, all the inflammatory markers at least were negative, including COVID antibody and D-dimer, ferritin, etc. Everything was normal. Though we did not go into the APLA, ANCA and all those because this was just the first episode and we were not very like thinking in those lines. Because of these infarcts in the watershed areas, our first suspicion was moya moya. And because also there were 2 episodes which happened on both the sides.
And how
And
old
both
is
have improved completely.
7.5-year-old, sir.
1.5? I mean,
I think of dissection.
So is there anything to suggest dissection in the first scan?
Sickling has been done. Sickling.
Yes, sir, it's negative. Yes, sir,
Sickling was
it's negative. So only thing came positive was because of the fever, we have sent nasal swab which showed influenza B positive. That's it. Yes.
That was the trigger, but
Yeah.
for, right now it is looking non-progressive. But like,
Yeah.
what should be the further course here? We did not give any steroids at that point of time because none of the inflammatory markers were positive. But there is a significance still. There is a stenosis of the ICA. So, what should be the management plan and any etiology we can think of on these scans?
and any other blood vessels like the renal vessels have been imaged in any way?
No, sir.
No, we have not done that. I think that's a good idea.
Yeah, blood pressure, etc. There's no indication for a systemic problem, right?
The pulses and all were okay. Blood pressures were okay, but we have not done any Dopplers or any
Because this is a
formal
large vessel
studies.
disease,
of the
large
renal
vessel
and-
disease in outside the context of any obvious trauma. I mean, of course, in children, you don't need trauma for a dissection of the vessel, which I still can't exclude as an etiology here. The left side is pristine and probably will supply most of that contralateral head. I don't think the vascular change completely can be labeled as watershed only in this respect,
Okay.
because you have an obvious vasculopathy going with it of a large vessel. It will still be useful to baseline the kidneys, making sure that there's, I guess you've done the blood test for any impairment, but any
So we
system,
have not done renal and Doppler studies. No.
you might want to see if there is any systemic handle to this, which might help you with the diagnosis. Otherwise, it seems to be localized to a large segment of the internal carotid on the right side.
Sure. We'll get it done. Yeah.
And I don't think it was related to the fever per se, right, or the influenza as well, unless you had a proper neck infection going on at the same time.
Can I ask, would it make sense to measure perfusion and perfusion reserve to see whether he is at risk of further infarct?
Can
So
do, but
actually, we had suggested for perfusion as well as vessel wall imaging and all. They said that the changes have not progressed since the last scan. In fact, they have improved. So they did not actually do the further imaging. They have only the MRA. So we may consider doing that for fusion
So
imaging
I
as
have,
well
I
as.
have one question. I have one question for all of you. I mean, when Moya
The
Moya
child is,
started in the early period of Moya Moya, you might not see many collaterals, but this doesn't look like a typical Moya Moya either, right? In terms of the vasculopathy.
We call it just a transient multifocal arteriopathy due to influenza, like what to label it if it doesn't progress in the further scans also. When are these entities known?
I've not heard of it with influenza.
Any other opinions? Dr. Lokesh?
No, I think the
Ramesh,
imaging features are more inconsistent with the chronic critical stenosis. That's why the area of infarct and the type of infarcts. I think what is the gap between the two images of the
6 months.
6 months. The
Yeah,
first was
yeah.
in October, I think, and this is the second one in April.
Yeah.
So there
So
are
we have
no
had
new
two-
infarcts. Yeah.
Yeah. We had 2 children with unilateral Moya Moya kind of thing who got operated, but they had progressive symptoms. They had second stroke, one had third stroke as well. So then we operated. Excuse me. So I think those phenomena is not yet seen in this child, but I think we need to have a close observation for any recurrence of stroke or TIA.
So I'll do the renal vessel imaging as well, and maybe 6 months later, I'll repeat a scan and see what is happening to these vessels. Is there any, or if he gets any episode in between, any event in between. So we have many of such cases where we are not able to really, the arteries just remain stenosed like that. I mean, whether they're occluded or whether there is a vessel wall abnormality which is leading to that narrowing, we are never able to decide that, and we end up giving aspirin for maybe 2 years and then stop it. Most of them do not get any recurrence, but of course the cohort is very small, maybe 6 to 8 cases.
I think many centers have similar problems, Kavita. They don't know what they're dealing with.
Yeah. Okay. Thank you.
Okay, right. Thank you. Case studies from Dr. Rashmi. Gautami, if you're there, you can present the case.
Yes. Good evening, everyone. I am presenting history of a 10-day term baby boy delivered to a primigravida mother by emergency LSCS in view of hydrops fetalis and anhydramnios. Baby was non-vigorous, cyanosed, needed resuscitation. Positive pressure ventilation was given, followed by intubation. After intubation, saturations improved up to 84%. Apgar scores were 6/10 at 1 minute and 9 out of 10 at 5 minutes. Mother had history of fever in her first trimester. On examination, there was no dysmorphism. Baby had low set tears. Initially, baby had borderline saturations on ventilator. There was generalized edema. Most prominently left side of the neck and chest, there was edema. On auscultation, air entry was bilaterally equal with normal heart sounds. Per abdomen, there was no organomegaly. Activity improved after resuscitation. AF was at level. And neurosonogram done on day 2, it was suggestive of query vein of Galen malformation. And neurosonogram was repeated again on day 8. It was suggestive of hemorrhage in right lateral ventricle, mildly dilated tortuous vessels, noted mainly in the midbrain and thalamic region, query AV malformation. Both caudate nucleus and thalami are mildly bulky and mildly hyperechoic. Baby was noted to have 3 episodes of seizures in form of uprolling of eyes and left arm stiffening on day 9 of life, for which loading dose of phenobarbital was given at 20 mg per kg. EEG was done. Reported background normal for age, multifocal epileptogenicity, 3 clinical and electrical seizures associated with left centrotemporal spike, spreading to occipital regions and right side. Following loading dose of phenobarbital, baby had 2 more episodes of seizures. Hence, maintenance dose of phenobarbital was started on day 10. CSF analysis was done, showed 9 cells, neutrophils 2% and lymphocytes 7%. Sugar was 49 mg per deciliter, corresponding GRBS 108, and protein was 395 mg, and plenty of RBCs in the background. CSF meningoencephalitis panel and chikungunya PCR reported negative. CSF culture sensitivity reported no growth. COVID antibody IgM was negative, but IgG positive in the baby. Yeah.
Okay. Dr. Ashmi, do you want to add anything? Just
No, I think Dr. Gautami has presented the child.
Yeah.
The main thing is initially the baby had a lot of high drops. So there was edema everywhere in the child, ankles and everything like that. And they were worried about AV malformation in the first few days.
Okay.
But then later on, the baby developed seizures, and obviously Dr. Nihaal will tell us about the MRI now. Yeah.
Just to, before going to the MR, anything on the blood, hematological abnormality, coagulopathy?
Oh yeah, forgot to say, there were low platelets. The platelets have been consistently low, 50, 70 and all that. I think only recently.
30,040 yes, ma'am.
Yeah.
3 platelet transfusions were given.
Yeah.
Okay. Okay. Moving on to the MR. And on the MR, you have the T2-weighted sequences on top. And you have these areas of multifocal areas of micro and macrohemorrhagic foci in the right frontal region, the bilateral basal ganglia. The choroid plexus also demonstrates hemorrhage, and it is slightly asymmetrical in comparison to the contralateral side. The hemorrhage extends up to the occipital horns on both sides. There's also cerebellar hemorrhage. If you come down to the SWS sequences, the hemorrhages are more prominent, and you can appreciate the multiple microhemorrhagic foci in the bilateral cerebral hemispheres. The right lateral ventricle demonstrates intraventricular hemorrhage, and also the vermis and the cerebellar hemispheres on both sides have these hemorrhagic foci. Contrast images. The right choroid plexus again is slightly asymmetric in compared to the left side. There is some tortuosity of the vessel. This is the MR angiography source images. Some tortuous vessels are demonstrated, and also the choroid plexus is slightly more bulky in comparison to the left. There are also some collateral form or tortuous or collateral vessels in the vessel systems on both sides. The MR MIP sequences of MR angiography and venography do not demonstrate any obvious AV malformation, but these are MIP images. At this point, we are dealing with foci or multifocal areas of early subacute hemorrhage, and the various causes of non-traumatic hemorrhage, as listed by the paper by Dr. Mankad and also from the CHOP group, have demonstrated these causes. Coagulopathy is a leading cause for the hemorrhagic disorders, hence the question was asked. I'm not sure if there's sepsis or not, clinical sepsis. Dr. Rashmi?
Oh yes, yes. The baby had evidence of clinical sepsis. I'll come to it. Yeah. So we okay. I'll come to it later. Yeah.
Yeah. So the only question was, is there AV malformation in the right choroid plexus? It is bulky in comparison to the left, but there is no evidence of the malformation of the or the nidus on the, at least on the MIP images. So is it just hemorrhage which is causing engorgement of the vessels and it has become tortuous? I think a CT angiography or DSA would be more helpful, but I'll open the case for further comments.
I don't think there is an AVM in the choroid plexus. We don't get AVMs outside the context of a vein of Galen aneurysmal malformation in this age, in this population. And that is the choroid plexus hemorrhage, what you're seeing there. This is the commonest driver apart from coagulopathies. And then you kind of go down the list of the rare things, but common things being common.
Actually, we have thought about whether the baby could have congenital COVID with the mother having fever. So we have given IVIG to the baby, and the baby's made an improvement with that.
The question is, did anyone examine the placenta when the baby was born?
Dr. Ravuri, any idea?
No, placenta was not examined.
Yeah, generally with the feto-maternal problems, the placenta is always affected with the COVID type of cases with hemorrhagic changes in there. It would have been useful, but I mean, it's not always done right.
Hmm. Because the CSF protein is high because there was blood in the CSF, but obviously the panel and all the cell count and all is negative. But the baby behaved like a septic, looked like a septic baby on the day the baby had seizures, the day 9. So initially, everyone was thinking about the AV malformation, but after the seizures and with this thing, we were thinking whether it could be a COVID MIC, and then we gave IV immunoglobulins. Baby is
Yeah.
better actually with that.
The few described COVID neonatal presentations are like that. And I think it might be a relevant one in this case. But I don't know. More importantly,
Baby also had PPHN. I don't know if it was mentioned. Baby had PPHN initially and had during the ventilation all that. So yeah.
Just the detail, blood in the CSF also elevates the temperature, can mimic sepsis. At least in infants, this is well experienced.
All right. Okay. Thank you.
Okay.
So
Okay,
infection
thank you.
and sepsis related complications. Yeah.
Yeah. Thank you very much.
The next case is from Dr. Ramesh. If Surabhi is there, she can present the case. Geeta, do you want to present? Surabhi is in there?
Yeah, yes, sir. Yes, sir.
Okay.
So this was a 5-year-old male child who presented to us on the 10th day of illness. He had a history of fever for about 3 to 4 days, and later he developed certain behavioral issues and not interested in the surroundings. And later there was a decreased speech output was there. And then they have observed some extra, like some posturing, so more of a dystonic posturing. And on examination, he had more of a extrapyramidal signs with cognitive impairment was there. So clinically, we were suspecting autoimmune encephalitis, and outside MRI scan was done, which was suggestive of basal ganglia involvement. So we have sent the serum NMDA, MOG, and DMO, NMO. Like we didn't had a option to send for the basal ganglia encephalitis panel because it is not available here. And usually, and he was given a course of steroids and rituximab, but this child was not following the course. Usually we see a good improvement in these children, but he was not following the course. So we were suspecting like any other differentials based on this cancer. And so
Ceruloplasmin,
we have
is it significant?
ceruloplasmin was low, so we have sent urinary 24-hour copper also. The report is awaited, sir. And other TMS, CSF, which was done outside, everything was normal.
Ophthalmology, anything on the eyes?
Yeah, we have sent for evaluation, sir. The child didn't come for the follow-ups.
Okay. So I have the second scan, and on the T2-weighted sequences, you can appreciate that there is global reduction in the cerebral and cerebellar volume, and there is heterogeneous patchy hyperintensities involving the bilateral basal ganglia. Also slight hyperintense foci in the cerebral peduncles, which can be appreciated on the FLAIR images. Again, hyperintense change in the basal ganglia, but patchy and non-confluent. No areas of restricted diffusion. Nothing on the T1-weighted sequences. SWA, there is slight increase in mineralization in the bilateral global paradigm. On spectroscopy, we have this high choline peak and a inverted lactate peak. Reduced NA was also appreciated. Non-specific spectroscopy, which can be seen in inflammatory disorders, and also the lactate can be a marker for mitochondrial disorders, but given the clinical course and the basal ganglia involvement, we thought of possibilities of changes affecting the bilateral basal ganglia, that is the striatal necrosis lesions, and anti-D2R antibody was high in the list given the clinical presentation. Other differentials to be ruled out are the biotin thiamine responsive basal ganglia disorders, Leigh syndrome, glutamic aciduria, slightly unlikely. Post-infectious also, it is not likely in our case. Wilson's disease, given the low cerebral plasmin levels, but again, we'll have to evaluate the eyes and also the 24-hour urinary excretion. So at this moment, I'll open the case with a possible primary diagnosis of anti-D2R antibody related basic ganglion encephalitis.
More importantly, has the child responded to thiamine and biotin supplementation?
No, we didn't given a thiamine or a biotin supplementation to this child, sir.
Why? They're only multivitamins.
Yeah, like we were suspecting like a encephalitis picture, so.
Yeah, no, that's true. I'm just wondering because nowadays, as soon as in basal ganglia, they start giving it here. Nihaal, question for you: are the mesial temporal structures involved? Is the limbic system involved? I can't tell from those last.
No, they're not. The temporal lobes are usually hyperintense in our scanners. So that's more of a scanner related.
Is it scanner related? Okay, so we're not calling this limbic encephalitis and like NMDA.
Yeah. But I think NMDA can present with basal ganglia also. So
it can, yeah, that's why. And if you go
but
back,
I think there is negative NMDA, at least on the serum. NMDA test was negative.
But I don't know. It's a question for the neurologists here. The presentation of a 5-year-old with extrapyramidal and problems, as well as if you go back to the previous slide. Yeah, and with behavioral issues is very NMDA-like, isn't it?
Yes. Yes, sir.
Why not just add them?
This is the second scan, Dr. Kavita. I think the first scan also had a similar change.
First scan also has a similar changes, ma'am.
Okay.
And
in biotin thiamine, won't the thalami be affected much more prominently?
Yeah, much more common in the cortex.
Because here the thalami are completely spared, no?
Kavita
and
is
also
right.
in the first.
Thinking in that line, but I think ADEM at the end of the day is just a para-infectious phenomenon by and large, isn't it? So many things private.
And also in the first scan, there was a facilitated diffusion, sir. There was no restriction of diffusion.
At the same time, it could be a primary viral encephalitis.
Yeah.
But this is the second episode, right? I mean,
is it?
So the same episode, ma'am.
That's the same episode.
This is
Second
scan.
Okay.
Yeah, second scan.
Fine.
The atrophy can be attributed to the steroids, I think. Was there atrophy in the first scan too?
There was no atrophy in the first scans.
Okay.
I just had a question for you. Did you miss sending CSF NMDA? Because you did a CSF, but you sent a blood NMDA.
We sent a serum NMDA, sir.
Right. So you planned to send a, because CSF NMDA, as we know, has much more sensitivity than a serum NMDA, right? So I was just surprised that you did a CSF, because often you see patients.
No, we didn't do the CSF, sir. It was done outside.
It says CSF normal.
Yes, sir. CSF was normal. It was done outside. When the patient came to us, so we have sent the serum workup, sir.
So would you plan to do CSF NMDA, because serum NMDA is not of sometimes positive, you know, CSF NMDA might be positive. You still have suspicion of NMDA.
But serum is more specific and sensitive for NMDA, no, sir, than others.
Okay,
no,
but
that's for MOG. That's for
I
MOG.
will like to stand corrected, but I think MOG and NMO is serum. CSF is NMDA.
Okay. Agreed. Have you done a spine screening?
No,
we haven't done.
NMDA, do you get such symmetrical kind of lesions?
You can
restricted to the basal ganglia.
Normally,
what we have seen is just very asymmetric and patchy kind of hyperintensities.
No, you can get bilateral basal ganglia patterns. I still think that the mesial temporal is not completely normal, but I can't confirm that on single shot images. I think there is a bit of a limbic involvement here.
Okay.
Yeah, that finishes our case. I have just 2 follow-up cases from previous discussions with genetic follow-up. So this is a case from Dr. Ramesh. I'll just quickly go through the presentation. The child was a 4-year-old boy, presented with febrile illness, hematuria, had acute kidney injury with autoimmune hemolytic anemia, had hypertension and required 4 antihypertensives to control the hypertension, had cardiorespiratory arrest, followed by seizures and encephalopathy. Developmentally had slight speech delay with possible autistic features. This was the initial scan done in February, and you have these areas of bilateral cerebellar edematous changes. The sputum of the corpus callosum are also showing these edematous changes. The right basal ganglia, the right frontal and bilateral parietal regions also had these focal lesions. Nothing was seen on the diffusion weighted sequences. SWI had these multiple microhemorrhagic foci. A follow-up scan was done, and the follow-up we had these symmetrical areas of restricted diffusion, the bilateral globus pallidi and the cerebral peduncles. The cerebellar changes had almost completely resolved. Even the right frontal change also there's interval reduction in the right frontal lesion. Again, microhemorrhagic foci in the bilateral cerebral hemispheres. Nothing specific on the spectroscopy. At this point, given the kidney injury and hypertension, we thought of breast and microangiopathy. Causes of non-traumatic hemorrhage. There were some abnormalities in the hematological parameters such as autoimmune hemolytic anemia. Bilateral globus pallidus changes, the metabolics and disorders were considered, and also hypoxic injury given the cardiorespiratory arrest. COVID was a less likely possibility. The child was sent for genetic analysis, and it came for a likely pathogenic variant of a syndrome known as Finca syndrome, which is caused by the NHLR-C2 mutation. So it stands for fibrosis, neurodegeneration, and cerebral angiomatosis. The scans were non-contrast. We could not appreciate any angiomatosis, and the literature has mentioned, at least on the imaging findings, the main findings are only in the corpus callosum. They have mentioned it as thin corpus callosum. Only one patient they have mentioned changes of increased signal in the globus pallidus. No images are being presented in this paper. So just to ask the panelists for their comments. Do they have any experience with this syndrome, this mutation? There was no chest findings, as far as I know, in our case. But yeah, any experience or any comments on this case?
No
And
experience.
is the gene pathogenic?
Don't know about the gene being pathogenic, but no, I've not seen this one. And really, can you call this Finca without fibrosis, without the F, with the Inca syndrome?
No, there's no angiomatosis too. So
yeah,
there's no
see,
scar.
see Inc syndrome.
There's only neurodegeneration. So that's the only finding I have on brain mark.
We'll think a little bit more about this gene and let you know.
Yeah. Okay.
What is the function of gene? I mean, sorry, I shouldn't be asking radiologists that question, but it would be useful if the imaging can be explained in some way. That's fine, but
no, the imaging doesn't fit us. Yeah.
Just the neurodegeneration.
Yeah. Okay, I'll check with Dr. Ramesh and get back.
Yeah.
This is another follow-up which we had from a case discussed in February. Iti, if you're here, you can quickly present the case.
Yes, sir. This child we had were basically presented with seizures, multiple episodes of seizures, was developmentally normal and complete normal neurological examination. And the EEG was showing some epileptic abnormalities. And MRI was like leukodystrophy kind of a pattern and sparing the U fibers. However, the child was absolutely developmentally normal till that age.
Okay.
So for this, we had sent genetics.
Okay, I'll take it from here. So here again, you have diffuse white matter abnormalities, relative sparing of the U fibers and the corpus callosum, no cortical malformations, deep gray nuclei are normal. At that point, we thought of possibilities involving this panel, the diffuse cerebral panel, which had these abnormalities. and genetics came out for a VUS, but for Llama A2 mutation. These are literature examples of these diffuse periventricular predominant white matter abnormalities, and to open the case for further comments if the gene is likely to be pathogenic or not, based on the imaging and clinical presentation.
CPK in this child after the gene came positive was done, which was normal. 2D echo is normal. So heart and muscles muscles have not been involved till now, and seizures are under control. Child is doing absolutely fine. So on literature review, when I checked the natural history of this mutation, it was like they have onset in mid-childhood to adolescence, and they continue to be ambulant till 22, 23 years of age. Some of them may just have some proximal muscle weakness, and so it's one of the good muscular dystrophy actually.
Actually, I have got one patient with LAMA2 mutation who had a CNS presentation with CPK normal. So we cannot say dystrophy because CPK is normal. So this is not a, there is no muscle involvement, right? So,
Right.
so it's like a MRI of GPR56, you know, which is not GPR56, but similar sort of disorders. And my patient also has similar sort of leukodystrophic changes with occipital epilepsy, with no muscle involvement, and he is a LAMA2 homozygous. It was reported as VUS because, so maybe there is a CNS form of LAMA2 which presents like this.
Sir, how is he developmentally, your patient?
He's 6 years old.
No, is he normal is the question.
Is he normal development?
Normal.
Okay.
He's a normal child.
Okay.
My experience is limited. I'm aware of a girl with a LAMA2 mutation. She is in the wheelchair, bright, cognitive, attending regular school, but very, very severely impaired from her muscular situation. And the image is less pronounced than this image. It's more focal, but it's a LAMA2 variant biallelic. Obviously a spectrum.
Because if there was a dystrophic presentation, CPK should be high even now. So having a normal CPK in a genetic disorder is odd.
Okay.
Reminds me a little bit about a HEPA-CAM kind of situation where you have a an otherwise normal patient.
Are you testing the parents for?
Sorry, sir.
How will you counsel the
family? As of now, I've sent the parental testing, so they are yet to come. I've not counseled them yet, but I think I'll tell them the same thing, that this child might have problems later in ambulation, because some of them can develop gait disturbances in later adolescence. So that only needs to be counseled as of now.
Thank you.
Okay, thank you. And that should be our last slide. So once again, yeah.